Okay, so now I'm going to talk about the antihypertensive agents. So I did have AI make me a little quick cheat sheet so I don't have to keep writing everything down. But don't worry, I'll be explaining everything. So, first of all, let's talk about why does any of this matter, right? Obviously, we know why it matters, but let's really get into the big picture of all this. So, your blood pressure is basically the force your blood pushes against your vessel walls. So think of it like a water pressure in a hose. So too much pressure for too long, the hose is going to start to wear down and then it's going to eventually break. So in the body, the breaking down is going to look like a few things. So it's going to look like a heart attack, it's going to look like a stroke, heart failure, kidney damage, arrhythmias, like so on and so on. So something that the professor did say in class is that there are no symptoms while the damage is happening. So people usually feel fine, so they skip their medications. But by the time they feel like something is going on, the damage is already done. So now let's talk about what is a normal blood pressure, right? So let's talk about normal blood pressure. Right. So the professor said that like the old guidelines were like written back in like 2017 or something, but he kind of simplified it for us. So right now, normal would just be around less than 120 over 80. Elevated would be around 120, 129, right? And then less than 80, right? So then you're going to have stage 1, stage 2, and then an hypertensive crisis. So in stage 1, you're looking at around 130 over 139 systolic, and then diastolic around 80 to 89, right? So this, he said, used to be considered fine, but it's not anymore. And so now stage 2, you're going to be looking at 140 plus over 90 plus. When you reach a hypertensive crisis, you're actually looking at 180 plus over 120 plus, right? This, you're looking at a medical emergency. Okay, so at this point, this is where you're going to need IV drugs. All right, so this is important to note. Hypertensive crisis, 180 over 120. This is when we're going to start needing our IV drug. So that's something we need to keep in mind. All right, so now let's talk about, he did talk about some formulas in class, so I think it's only fair to kind of talk about them a little bit. So let's just talk about what blood pressure is. So your BP is going to equal your cardiac output times your vascular resistance, right? That's all that it is. So every single hypertensive drugs works by attacking one or both sides of this equation. So either your cardiac output or your vascular resistance. So your cardiac output, that's literally just going to be how much blood the heart pumps. So that's going to be your heart rate times your stroke volume. So again, how much blood the heart pumps. All right, so now let's look at what vascular resistance means. So your vascular resistance is just how tight and narrow your blood vessels are. So just how tight / narrow the blood vessels are. So now to lower your BP, there is around 4 things that you can do. So let's talk about the things you can do to lower your BP. your blood pressure. So around 4 things. So the first thing that we can do is that we can make the heart pump less, right? So if we're gonna make the heart pump less, what does that mean? You wanna decrease your cardiac output, right? How is this done? It's gonna be done via your beta blockers, okay? So now the second option you have is to relax your blood vessels. So what does that mean? We want to decrease our vascular resistance. So our vascular resistance, that means we're going to be using, as you guessed it, alpha blockers, CCBs, vasodilators, okay? So all those things are gonna decrease our vascular resistance. So the third thing that he said that we use, but not much anymore, is gonna be removing the fluid from the system. So what does that mean? Diuretics. Diuretics, right? The fourth option that we have is messing with the hormonal system that controls both. So that means we're talking about ACE inhibitors as well as ARBs. So we'll obviously get more into all of what all of this means. Okay, so there's going to be 2 systems that's going to be driving high blood pressure. So almost all of our hypertension comes from these two systems being overreactive. So the first system is going to be your sympathetic nervous system, right? So obviously we know it as our fight or flight. So when it fires, our heartbeat is going to go faster and harder. So we're going to have what? Increased cardiac output. And our blood vessels are going to squeeze tight. So we're going to have increase in vascular resistance. So the result is going to be increase in what? Blood pressure. As we said, blood pressure equals cardiac output times your vascular resistance. So the CNS is going to do this through catecholamines, right? So catecholamines, right? So we're talking about epinephrine and norepi, right? So where do those bind? We know they're going to be binding on the heart and on your blood vessels. So now the second option that we have is going to be the RAS system. So the RAS system, so 2. So your, RAS system. All right. So your RAS system, aka your renin, angiotensin, aldosterone system. So this is the way your kidneys work to control your blood vessels. So this is going to happen in your kidneys, right? So when your blood pressure drops too low, the kidneys are going to release a chain of reactions, right? So the first thing that's going to happen is, number 1, we're going to have renin, right? Renin is going to be from where? From your kidneys, right? Renin from the kidneys. So from there, we're going to have angiotensin 1, angiotensin 2, right? Which obviously, as we know, angiotensin 2 is going to be the most potent vasoconstrictor in the body, okay? So it's going to be most potent vasoconstrictor in body. Okay. So from there, after angiotensin 2, we're going to make what? Aldosterone. Right? So aldosterone, what does that do? If you remember in physio, aldosterone is going to make you retain salt and water. All right, so again, what's the RAS system? Go from running it from the kidneys, angiotensin 1, 2, aldosterone. Angiotensin 2 can be the most potent vasoconstrictor in the body. Aldosterone is going to make you retain salt and water. All right, so the result is that your blood vessels are going to squeeze and it's going to hold on to more fluid, right? So your vessels are going to squeeze and hold on to more fluid. So ultimately what's going to happen, your blood pressure is going to go up, right? So the drugs we use are either going to block the CNS or block the RAS system, or they're going to go block both. Okay, so first, let's talk about our diuretics, okay? So the simple idea is that we're just trying to get rid of extra fluid, okay? So at this point, so there's less volume pushing against the blood vessel wall. So that's literally all that we're doing, trying to lower the amount of volume pushing against the blood vessel wall. So the drug that we have to know here is going to be hydrochlorothiazide, HCTZ. So now let's talk about how does it work, right? So HCTZ is going to, so it's going to block sodium reabsorption, right? So when it blocks sodium reabsorption in the kidneys, it's going to happen in the early distal tubules, right? So when sodium leaves, water is going to follow it, right? So what happens? Less fluid is going to be in the body. So again, so we're going to have hydrochlorothiazide. And what does it do? It's going to block sodium, right? Reabsorption in the kidneys, early distal tubules. All right. So when sodium leaves, right, what happens? When Na leaves, water follows. All right, perfect. All right, so what ultimately happens? We're gonna have less pressure, but the thing is, there is going to be a catch. So what is this catch, right? So when potassium also follows sodium out, right? Because what else is going to follow sodium? Potassium. So we're also going to have potassium following sodium. All right, so it's going to follow it out. So what's going to happen? You're going to get hypokalemia, right? So that's going to be the main side effect. So we're always going to have to monitor the potassium levels in the patient when you're giving a diuretic like hydrochlorothiazide. All right, so now let's talk about when is it used, right? When do we use it? So it's not going to be the first line of defense, as we said, anymore, but it's going to get added when other drugs aren't controlling the BP enough. So when it's usually combined in one pill with like when ARB, as we'll discuss, like telmisartan, that's usually one of them it does. So it's always going to be combined with an ARB, which obviously we're going to get into more details about what that is. So for now, just know a diuretic. The diuretic we have to know is going to be hydrochlorothiazide, right? It's going to block sodium reabsorption in the kidneys. So what does that mean? It's going to block it in the early distal tubule. So sodium's going to leave. What's going to follow it? Water and potassium. You're going to be left with hypokalemia if you don't monitor it. Okay. So now let's talk about alpha-1 blockers. So here we're going to have 4 drugs that we have to know. 4 drugs. Okay. So the simple idea that we have to understand here is the fact that norepinephrine normally binds to your alpha-1, right? So we're going to have norepinephrine binding to alpha-1. So what happens? So when that happens, where do you find alpha-1? Your blood vessels, right? So when that happens, you're going to get, vasoconstriction, right? Okay, so you're going to get vasoconstriction. So so right now these alpha-1 blockers, what are they gonna do? They're gonna block that receptor so the vessels can relax. So that's the point of your alpha-1 blockers, to block the alpha-1 receptor so we don't get vasoconstriction. All right, so the drugs that we have to know, there's gonna be prazosin, doxazosin, tetrazocin, and then Phil, right? That's the only odd one out that we don't, so phenylethylamine, that doesn't end with azocin. So if you see an alpha-1 blocker, you're going to know it because it's going to end with these guys, azocin, so azocin. So the mnemonic that they made up is like, please don't trip Phil. So please don't trip Phil, alpha-1 blockers, right? They're going to be peripheral acting. Okay, so these same alpha-1 receptors are also going to be in your prostate, right? So if you block them there, the prostate is also going to relax. So these drugs can treat both hypertension and enlarged prostate, so benign prostate hyperplasia, so BPH. So that's going to be probably an exam question. So we know that alpha-1 also found on prostate. So we can use these alpha-1 blockers to treat BPH, so benign prostate hyperplasia. Right, so we have an exception here, right? Phil, out of please don't trip Phil. So we're going to have who? Phenoltolamine. So who is phenoltolamine? So phenoltolamine is going to block alpha-1 and alpha-2. So we're going to have it blocking alpha-1 and alpha-2. So, but it's only going to be used for what? It's only going to be used for phenochromocystoma. So what is that? It's just going to be a tumor of the adrenal gland, and it's just going to keep dumping out catecholamine. So this is not going to be used for regular hypertension at the end of the day, as we have it said right here. Not used for regular hypertension. So now there are alpha-1A selective drugs. I don't think they were written here, so I'll just have to write it out. All right, so you're going to have alpha-1A selective drugs, right? Those only work on the prostate. I don't know if we really have to know them, but so I'll just write it here. Alpha-1A selective drugs. Again, they only work on the prostate. Okay, so what are they? I'm just going to write them down. So it's going to be one, it's going to be your tamsulosin. 2, your sildosin. And then 3 is going to be your alfluzocin, right? So these do not lower blood pressure. So do not lower BP. They only act on the prostate. So we said the only 3 that do work on the prostate is going to be that also work on the prostate, but they also treat hypertension. You're going to be looking at what? Prazosin, doxazosin, and tetrazocin. Again, what are they end in? AZOSIN. So please don't trip Phil. And again, phenolphthaleamine is only going to be used in treating phenochromocystoma, and it's going to work on 2 receptors, alpha-1 and alpha-2. What it's going to do is going to block it, because what's going on in phenochromocystoma, you're going to have an increased production of catecholamines, usually because of a tumor. Okay, so now let's talk about our central acting alpha-2 agonists, okay? So these are going to, so your alpha 2 receptors, right? Let's first talk about where they're found. So they're going to be found where? They're going to be found on your presynaptic terminal, right? So these are going to be found on your presynaptic nerve terminal. So it's going to be the nerve itself, not the blood vessel, okay? So just on the nerve, so on the nerve. Nerve, not your blood vessel. So ultimately, their job is like just a feedback mechanism. So when there's too much norepinephrine in the synapse, alpha 2 is going to get stimulated and it's going to say stop releasing more norepinephrine. So this is just going to be a negative feedback mechanism. All right, so we have increased norepi. It's going to bind alpha 2 at the presynaptic terminal on the nerve. Oh no. What is that going to do? It's going to block norepi release. All right. So these drugs are going to mimic that feedback. So they're going to stimulate the alpha 2 in the brain. The brain releases less norepinephrine. The sympathetic system is going to quiet down, and your blood pressure is going to drop. So all these drugs are doing is just going to be mimicking this negative feedback mechanism. All right, so the drugs in question is going to be clean guys give meds, right? So it's going to be your clonidine, guanabens, guanafacin, and then your methyl dopa. Okay, so clonidine is going to be the main one that we're going to focus on for now, right? We talked about it a million times in lecture. So this is going to be extremely lipid soluble, all right? It's going to be extremely lipid soluble. So it's going to cross what? It's going to cross your blood-brain barrier. Anything that's lipid soluble is going to cross your blood-brain barrier. So it works well, but it's going to have a lot of side effects. So you're going to have dry mouth, depression, sedation, fluid retention, and it just a whole lot of bad things. So you're going to have your dry mouth, depression, right? You're going to feel sedated, so very, very tired, and your fluid retention. Right. Okay, so he did mention two important points in class that we do have to know is that, one, you can never stop taking it suddenly, because if you stop taking clonidine suddenly, you're going to get life-threatening rebound hypertension. That's the first thing. So you're going to get life-threatening rebound hypertension if you stop it. So that's the first thing. So the second thing, it treats opioid and nicotine withdrawal symptoms. So that's going to be a classic board question. He said is probably going to be asked too. So don't stop suddenly, right? Because rebound hypertension, right? That's number one. And then it's used to treat opioid and nicotine addiction. Okay, so again, clean guys give meds: clonidine, guanabens, guanafacin, and then methyl dopa. All right, so let's talk a little bit more, actually, before I forget, about methyl dopa. So methyl dopa is very, very special because it's a drug of choice for hypertensive pregnant patients. So it's gonna mostly be used in hypertension in pregnancy, right? So it's gonna be used in hypertension in pregnancy, right? That's methyl dopa. So it's gonna have two mechanisms. So first, it's gonna act like an alpha 2 agonist, as all of them do, and something that we called a false transmitter, right? So what does that mean? So a false transmitter is just when it's going to sneak into the norepinephrine synthesis pathway. It's just going to disrupt it. So it's unique because its side effects are like lupus-like syndrome. So you're going to have something called the false positive Coombs test. So you're going to have here the false positive Coombs test, right? And you're also going to have liver enzyme elevation. And again, you're going to have lupus-like symptoms. So again, we said that methyl-dopa, as well as it being an alpha-2 agonist, it's going to be what? It's going to be your false transmitter. What does that mean again? All that it means, it's going to sneak in and it's going to stop the norepinephrine synthesis pathway. So it's just going to disrupt it. So disrupt norepinephrine synthesis pathway. Okay. All right. So now let's talk about our peripheral acting adrenergic blockers. So AKA, we're going to block norepinephrine at the nerve terminal. So these work not in the brain, but they're going to work at the nerve endings in your body, right? So we have 3 drugs here, and we're going to call them the really good guys. So the peripheral acting androgenic blockers. So we have reserpine, guanidril, and guanethidine. Please do not get these 2 groups of drugs mixed up, okay? The central acting alpha-2 agonist, right? Where do we say it happens? In the presynaptic terminal alpha-2. The peripheral acting adrenergic blockers, those are going to happen where on the nerve endings in your body. So these are going to work on the nerve endings in your body. All right, so again, the 3 drugs you have to know: reserpine, guanidril, and guanethidine. Okay, so first let's talk about reserpine, right? So reserpine, honestly, is my favorite. I don't know why. I like anything that has to do with like VMAT, but so it's going to block VMAT, right? So VMAT, that's the transporter that packages dopamine into the storage vesicles where it can become what? Norepinephrine, right? So if you have no packaging, over time, your norepinephrine stores are going to get depleted. So again, VMAT, right? That is where it's going to take your dopamine that's in your inside your cytosol, and it's going to bring it, and it's going to go inside the vesicle, where then dopamine is going to become norepinephrine. So again, over time, your norepinephrine is going to get depleted because no dopamine is entering the vesicles to become norepinephrine, because that's the only place where dopamine can become norepinephrine is inside those vesicles. So reserpine usually takes around 2 weeks to work. There are a lot of severe side effects that come with this medication. So first of all, you can get CNS depression, Parkinsonism, orthostatic hypotension, and very, very severe parasympathetic overactivity. So you're going to get bradycardia, nasal stuffiness, GI issues, and worsening of glaucoma. So again, reserpine, let's like kind of break this down, right? What is orthostatic hypertension? It's pretty much when you're sitting and then you get up, right? And then your blood pressure drops, right? So reserpine can cause that. And then, so you're going to get the parasympathetic overactivity. What is that again? You're going to get bradycardia, nasal stuffiness. Why? Because when you have dilated blood vessels in your nose, then you're going to have increase of what? Like inflammatory cells going in and causing that stuffiness. Okay, so now the second one I want to talk about is going to be guanethidine. So guanethidine is going to block the release of norepinephrine, and it's going to deplete it. So it's going to be the most potent antihypertensive that works this way. So it has to be taken up into the nerve terminal for it to work. So which means like things like, I believe he said cocaine and tricyclic antidepressants, which, that block that net transporter, will prevent it from working, right? So you're not going to get any drowsiness from it because it doesn't cross into the brain. So the classic side effects you're going to be looking at explosive diarrhea, parasympathetic overactivity. So it's not really used clinically anymore either. So I really wouldn't worry too much about it. But yeah, so those are the two main ones that he talked about in class. He really didn't go into detail about guanidinol. So for now, we'll kind of skip it. But again, I do want to emphasize, for guanidinol to work, you need, it's going to block the release, right, of norepinephrine. It's going to deplete it, as we said. But it needs to be taken up into the nerve terminal. So if it needs to be taken up into the nerve terminal, that means NET needs to work. So as you know, cocaine blocks NET, right? So if cocaine blocks NET, that means guanidinol can't cross into the nerve terminal using the NET enzyme. So it's going to be stuck, so it won't work, right? So as we said, again, NET, right? You need NET. So cocaine is going to block that path. So if you take cocaine with guanidinol or, again, tricyclic antidepressants, it's not going to work. All right. So now let's talk about our ACE inhibitors. Everyone loves them. So our ACE inhibitors, they're going to block the RAS cascade. Okay, sorry, my throat got dry. So back to what we were talking about, ACE inhibitors, right? What do we say it does? It's going to block the RAS cascade. So here, it's going to block the RAS cascade. All right, so this is going to be one of the most important drug classes that we're going to talk about. So again, just so we understand what it is, you're going to start with what? Angiotensinogen, renin, it's going to become renin. Then you have angiotensinogen 1, the ACE enzyme, forming angiotensinogen 2. So let me write that out. So you're going to have angiotensinogen, right? Going to become renin, right? And then you're going to have angiotensin 1. Then here, this is where the ACE enzyme comes in, right? You're going to have angiotensin 2, right? Then you're going to have vasoconstriction plus aldosterone release. Okay, so what we really have to focus on here is going from angiotensin 1 to angiotensin 2 via what? The ACE enzyme. So your ACE inhibitors, they're going to block the conversion step between, so they're gonna stop this conversion step, right, from angiotensin 1 to angiotensin 2. So we're not gonna get angiotensin 2. So if we have no angiotensin 2, what does that mean? Our vessels are gonna relax, and what else? There's not gonna be any aldosterone. So we're going to have less fluid is going to be retained. So less fluid retained. Okay. So he also said there's another mechanism that kind of drives into all of this. So ACE normally is going to break down bradykinin, right? So bradykinin is a vasodilator. So usually ACE enzymes break down bradykinin. And bradykinin, as we said, is a vasodilator. So right now, again, we're talking about ACE inhibitors. So this is what we're trying to inhibit, right? So this enzyme converts angiotensin 1 to angiotensin 2. If you block this enzyme, you can't make angiotensin 2. You can't vasoconstrict, no aldosterone, so you're going to have less fluid retained. So if you have less fluid retained, right, that's better. You're going to decrease your hypertension. Another thing that ACE enzymes do is going to break down bradykinin, which is a vasodilator. So ACE inhibitors is also going to stop the breakdown of bradykinin, right? So we're going to have increase of bradykinin is going to build up. So if we have more bradykinin, right, we're going to have increase in vasodilation, right? So we're going to have increasing blood pressure lowering. That's why it works so well, right? So, but the same bradykinin buildup is going to be the same reason why it's going to cause what? A dry cough. So when you have excess bradykinin, you're also going to have a dry cough when it goes into increased amounts. So that's the number one reason a lot of patients stop taking it, right? So let's now talk about the drugs. So the drugs all end in PRIL. All NACE inhibitors end in PRIL. Okay. So let's talk about when we use ACE inhibitors. So ACE inhibitors are going to be used in hypertension with diabetes, right? So it's going to protect the kidney. So it's going to prevent diabetic neuropathy, right? So that's one reason to use it. Another reason why we're going to use it is in CHF patients. So that's going to be the first line, right? Why it's going to reduce your preload and afterload. So again, the reasons we're going to use these ACE inhibitors. Number one, hypertensive diabetics. Why? It's going to protect the kidneys. Oh my lord, protect the kidneys. So it's going to prevent diabetic neuropathy. All right, that's the first thing. The second thing we're going to be used for is CHF, right? And so this is going to be, again, your first line, right? Why? It's going to decrease your preload and your afterload, okay? So why is this important? Because this is going to stop, right, the amount of work your heart is going to have to do. So when your heart is literally failing when you have CHF, you want to decrease the amount of work it has to do, which is why you would want to give an ACE inhibitor. Another reason why you would want to give it is going to be after a heart attack, right? So give it after a heart attack. Why? Because it's going to slow down left ventricle hypertrophy. So it's going to give after a heart attack, right? So it's going to decrease what? Left ventricle hypertrophy. All right. The last thing you want to give it for is going to be what? Chronic kidney disease, which makes sense. If you don't want to, like the RAS system, you don't want to vasoconstrict your kidneys too much, and then you're gonna have it's gonna be too much, right? So and ACE inhibitors it's really gonna help patients with chronic kidney disease, right? So your kidneys don't fail. So there's a couple of side effects that we have to know. So we're gonna have, again, the dry non-productive cough. So again, this is caused by what? By bradykinin, right, as we discussed. So it was said in class that when you stop bradykinin, when you stop ACE inhibitors, usually the cough will also stop. Another problem we'll see is that we're going to get hyperkalemia, right? So why does hyperkalemia happen? So let's do let me write this down. So side effects, number one, your dry cough via what? Bradykinin. Number two, you're going to get hyperkalemia. Why? Hyperkalemia is going to be, your potassium is going to build up because aldosterone is blocked, right? So that's going to be a huge issue. So if you block aldosterone, you're going to have an increase in potassium, because aldosterone helps excrete potassium out of the body. Another thing you'll have is angioedema, right? It's rare, but that is very, very life-threatening. So pretty much angioedema is when your tongue and throat is going to start to swell and you can't breathe anymore, right? So how is this treated? It's going to be treated with epinephrine. All right, so it's also going to be contradicted in pregnancy. So oh my Lord. Contradicted in pregnancy. Right? Why? Because it's going to cause fetal hypotension. All right? So this is going to be probably a classic question that we'll get. What can't you use in pregnant patients? You can't use ACE inhibitors. What are they? They're going to be everything that's going to end in pril. Literally pril. So, like a little summary of each one. Captopril, right? That's going to be the original one. It's going to have a short half-life. Enalapril is going to be the only one that's going to be available both IV and oral. Lisinopril is going to be long-acting, once daily. So is quinapril. All right. So the three that he did emphasize the most, which is true, is going to be captopril, enalapril, and lisinopril. So it's going to be these three that we have to know. So captopril is going to be the original one. It's going to have a shorter half-life. Enalapril is going to be the only one that's available both IV and oral. So enalapril, IV, and oral. All right. And then captopril is cap. So cap is short life. So cap means short, I guess. And then your lisinopril. So long-lasting, once daily. All right. So now let's talk about your ARBs. So what do ARBs do? They're going to block the RAS at the receptor, right? They're all going to end with what? Sartans. They're all going to end in sartans. So these are like the ACE inhibitors, but it's going to be like one step later. So instead of stopping it here at angiotensin 2, from angiotensin 2 from being made, ARBs is going to let it form completely. But it's going to block the receptor that's going to bind to. That receptor is going to be called the AT1 receptor. So these drugs are going to block the AT1 receptor, which is where angiotensin 2 and et cetera are going to go ahead and bind. So the results are going to be very, very similar. So you're going to have vasodilation, less aldosterone, but only because they don't affect bradykinin, they're not going to cause that dry cough. So an important thing, they don't affect bradykinin, right? What did we say does? It's going to be our ACE inhibitors. ARBs, the sartans, they do not affect bradykinin because because ACE is still being made, right? All right. So again, all the drugs are going to end in sartan, so it's great. So now let's talk about when we use ARBs. So ARBs is going to be the first line for essential hypertension, right? So first line in essential hypertension, all right? So these are going to be patients with no comorbidities, right? So it's going to be for a patient who's healthy, but they just have hypertension, right? You can combine it with the HZTZ pill. If we remember what that was your diuretic pill, right? So it's going to be the alternative to your ACE inhibitors in diabetics if they can't tolerate the cough, the dry cough that they can get. And then if someone develops a cough on the ACE inhibitors, usually they switch them to the ARB medication, okay? So The side effects for it is much better. It's usually very well tolerated. So you're going to get the occasional headaches, dizziness, and heartburn. The cough is very rare. You're going to get the same hyperkalemia and then the same pregnancy contradictions as the ACE inhibitors, though. All right, so next, we're going to be talking, wait, how many more sections do I have? 7, 8, 9. Oh, almost done. Only around 3 more sections. Perfect. All right, so now let's talk about the calcium channel blockers, right? The calcium channel blockers, all you're going to think of it as they're going to relax the vessels, right? Sometimes the heart, but by doing what? By blocking calcium. That's why they're called calcium channel blockers, right? So during muscle contraction, right, in your heart and in your blood vessels, what are they going to require? They're going to require calcium to flow into the cells, right? So if you block that, the muscles are going to relax, right? So there's going to be 3 classes that we're going to talk about. So the first class I'm going to talk about is going to be your dihydropyridines, right? So everything that ends with a PIN, right? DIPIN, anyway, dipin. If it ends with a dipin, it's a dihydropyridine, okay? So where is it mostly going to work on? It's mostly going to work on your blood pressure, and it's best for hypertension, as this whole lecture is about. All right, so let's talk about all the drugs. So the first one is going to be your amlodipine, right? So that's going to be the most commonly used one today because it's going to be the long-acting. So it's going to be long-acting and once daily. So it's easier. 3rd generation, it's one of the newer one, right? Then you're going to have nifedipine, which is 1st generation, and then you're also going to have the last 2, nicapridine, and then the one that looks like it's my name, isradipine, right? Isradipine and nicadirapine, right? That's kind of a nicaridipine. So Isra likes nicotine, I guess. That's a weird way to put that. I don't know if that will even work. I might have to scratch that whole this entire video now. But yeah, that's a fun mnemonic, right? Israel likes nicotine. Yeah, that's how you're going to know. 2nd generation, and Israel's in her 2nd year. I don't like nicotine, but that's a fun mnemonic. Now I won't forget that. I don't even know if I can post this now. But also, Philo. Philo's on here too. He's also 2nd generation. So Isra, Philo, and nicotine. Yeah, those are 2nd generations. We're all in 2nd year. That's funny to me. All right, so now let's talk about your phenylalkylamines, right? So this guy right here. So those are going to mostly work on your heart, right? So these are mostly on the heart, okay? So it's going to be both your SA and AV node. Sorry, I'm still on to how funny that is. Anyway, so it's going to be used for arrhythmia. So the main drug, right, it's going to be used for arrhythmias. Sorry, I got to get it together. It's going to be used for arrhythmias. And the drug you have to know is going to be verapamil. Okay, so verapamil acts on your ventricles, V for V. So your phenylalkylamines, one drug, works on the heart. Most of your SA and AV nodes, so we want to deal with your arrhythmia, so it's going to be called verapamil. So the third drug class we're going to talk about is going to be the benzothiazepine. So this is going to work on both, right? So the only drug we have to know is the diltiazem, all right? So now, the way you're going to memorize this is that if it ends in dipine, it's a blood pressure hypertension. and then verapamil is going to work on the heart, so it's an arrhythmic drug. So verapamil, as we said again, it's going to be a phenylalkylamine. Okay, so most of the side effects on dihydropyridines is going to be bilateral ankle edema. So the side effects is going to be bilateral ankle edema, right? So why? Because the vessels are going to dilate so much that the fluid's going to leak into the tissue. So if the patient is on a calcium channel blocker and you have swollen ankles, that's the drug. It's not heart failure. So you always have to roll, but you still do have to rule out heart failure when you see that. So other side effects you're going to get. So you're going to get the flushing, the headache, the constipation. You're going to get gingival overgrowth, so gum inflammation, and you get reflex tachycardia, which is pretty rare. All right. So now let's look at the last resort drugs. So we have 2 more sections. All right. So let's look at the vasodilator. So these are the last resort. So these directly relax your arterial and your smooth muscle, your arterial smooth muscle, right? So let's write this down. Directly relax arterial smooth muscle, right? So it's a very, very powerful vasodilator. So it's extremely powerful. So the problem is that they work too well, right? So their blood pressure is going to drop so fast that your body's going to panic and is going to fire off your baroreceptor reflex. Oh my God. Baroreceptor reflex, right? Causing what? Reflex tachycardia. Okay. So pretty much your baroreceptor reflex. So your baroreceptors are gonna sense that your blood pressure dropped, and then what it's gonna do, it's gonna increase your heart rate. So you're gonna get tachycardia. So it's very counterproductive. So you can never give these alone. So you always need a beta blocker first to prevent it, right? So here are your beta blockers. So the reason why you're going to give the beta blockers is to prevent tachycardia. So let me see what is the best drug to start with. I don't think I was able to write it down. Oh no. Alright, so I will just have to write out the drugs. Okay, so the first drug that we'll oh no, I'm highly blind right here. They're right here. I'm so blind. Okay, so the first drug that we're going to talk about is going to be hydrolysine. So hydrolysine, you're going to take it oral. So hydrolysine is going to be, it's an oral medication, as it says here. Okay, so it's going to use in severe refractory hypertension and chronic heart failure. So you're going to use it during what? Refractory hypertension and CHF. Okay, so he did say this is going to be a classic board question, so I'm assuming it's going to be an exam question. So he said that hydrolysine is going to be a slow acetylator. So pretty much people's liver is going to metabolize it very slowly. So it's going to be a slow acetylator. Okay, so liver metabolizes it slowly. Right. So what are you going to get? You're going to start getting things like lupus-like syndrome, right? Because, again, it's a slow acetylator. Okay, so you're going to get the side effects like rash, joint pain, but most crucially, you're going to get no kidney damage, right? Which is distinguishes it from real lupus, right? So you're not going to get, so, oopsies, no kidney damage. That's what's going to distinguish it from lupus. But again, you're going to get the joint pain and the rashes. All right, so the second drug is going to be minoxidil. Again, it's oral. So it's going to be for even more severe hypertension. So even more severe hypertension. Okay, so use it when nothing else works. Honestly, like minoxidil is like their last resort, and it's gonna also be used in patients with kidney failure. So also patients with kidney failure. Okay, so the fun fact that the professor said is that if you know what minoxidil is, if you've seen your dad or your boyfriend or your brother use it, it's going to cause your hair to grow back, right? That's a side effect of it. So, which is why it's become what? Rogaine, right? Which is topical. So this is most likely going to be an exam question. What is minoxidil? Hair growth, right? So now let's talk about, where is it? I might be blind again. Okay, we'll just start here. So let's start talking about the IV, right? They're going to be 4 emergency IVs. So your IVs, so the first one's going to be sodium nitroprusside. So IV only. So that's going to be for hypertensive emergencies, okay? It's only going to work within 1 to 10 minutes, right? So what does it do? It's going to release nitric oxide to cause vasodilation. So it's going to release nitric oxide to cause vasodilation, right? So the main risk of it, it's going to metabolize into, so the main risk factor is going to be that it can become, so it can metabolize into cyanide. All right, so this is AKA thiocyanate toxicity. Okay, so this is going to cause weakness, slurred speech, psychosis, metabolic acidosis. So these are all classic issues that we can see. So now let's talk about diazoxide. So diazoxide, again, IV long lasting, also hypertension emergency, but it's going to be contradicted in your diabetic patients. Why? Because it's going to block your insulin release, causing what? Hyperglycemia. So contradicted in diabetic patients because it blocks insulin release, causing hyperglycemia. Oopsies. Causing hyperglycemia. All right. And you also can't use it in patients with CHF, MI, or strokes because reflex tachycardia makes it worse. So don't use for patients with CHF, MIs, or strokes. Why? Because of reflex tachycardia, right? So again, diazoxide is going to cause reflex tachycardia in patients with CHF or had MIs or strokes. So also, another side note, diazoxide. It also cross-reacts with sulfa drugs. So if a patient's on sulfa drugs, don't also give it. So cross-react with sulfa. So don't give it. Don't give diazoxide with if the patient's on sulfa drugs. Okay. The last two is going to be the phenodolpan, again, IV hypertensive emergencies. You're also going to use it for post-op hypertension, right? So pheno is going to be for your post-op hypertension crises, right? It's going to be more unique because it's a dopamine D1 receptor, right? So dopam, right? Dopam for dopamine. So it's going to be what? So it's going to be a dopamine D1 receptor is what it acts on, right? So what's going to happen when it's acting on these dopamine D1 receptors? It's going to dilate the kidney arteries, right? So he did say to avoid in patients with glaucoma. All right. So the last drug we'll talk about in this section is going to be the trimethylaphan. So trimethylaphan, again, so this is going to be a ganglionic blocker used in hypertension crisis and then dissecting the aortic aneurysm. So used in dissection of aortic aneurysm, as well as it's a ganglionic blocker IV. Okay, so now let's talk about our beta blockers, right? So we're almost done. All right, so your beta blockers are gonna what? You're gonna slow down the heart, right? So beta blockers are to slow the heart rate, and they're gonna reduce how hard the heart's gonna contract. So you're gonna lower your cardiac output. So these are going to decrease your cardiac output. So there's 3 generations, right? There's gonna be first, second, and third. So your first generations are gonna be your non-selective. They're gonna block beta 1 and beta 2, as it says here, beta 1 and beta 2. So those are gonna be your propranolol, nadolol, timolol, piodonolol, and sotanolol, right? So all these guys right here, nadolol, pentanol, butanol, all these guys, right? It says here propranolol is gonna be the prototype. So just remember it separately because that's gonna be the classic non-selective drug in this case. That's literally as it says here. Right, so then second generation drugs are going to be your beta 1 selective drugs. So they're going to block only the heart, right? So only blocks the heart. Okay, so if you only block the heart, right? So let's first talk about the drugs. So we're going to be looking at, it's going to be like metoprolol, atenolol, bisoprolol, and ismolol. So there's going to be around 4 of them. 1, 2, 3. So we have 5, but I'll kind of explain them. So why does the selectivity matter, right? So beta 2 receptors are in the lungs, right? We know that. So if you block them, you're going to get what? Bronchial constriction. So that's dangerous in asthmatic and COPD patients. So your beta 1 selective drugs are going to be safer for these patients. So especially patients with, asthma and COPD, because it won't react on those beta 2 receptors. So they're also going to be safer in diabetics because what? Your beta 2 blockade masks the hypoglycemia symptoms. All right, so again, safer in diabetics. Why? Because the beta 2 blockade masks the hypoglycemia symptoms. So now let's talk about the last part of this all. It's going to be your third generation drugs. So they're going to be your vasodilatory drugs. All right. So your vasodilatory drugs, they're going to be your carvedilol, labetalol, right? So they're also going to block alpha 1. So, but the two things we have to know is that nebivolol, right here, nebivolol and beta-oxalol, right, both of these, they're going to cause vasodilation through nitric oxide or calcium, right? So nebivolol is going to be nitric oxide, beta-oxalol is going to be calcium. Okay, so their uses are going to be beyond hypertension. So usually they're going to be used as well in post-MI, heart failure, angina, so that's like pain, arrhythmias, essential tremor, migraine prevention, performatives, anxiety, thyroid storm, as well as phenochromatocytoma symptoms, right? So those are going to be the key side effects. So now let's talk about the key side effects. I'm sorry. So the key side effects, you're going to get bronchoconstriction. So the bronchoconstriction because it's going to be non-selective, right? So it's going to be contradicted with asthma. You get bradycardia, cold extremities, CNS effects. So you get the drowsiness, the nightmares, right? Especially for the lipophilic drugs like the propranolol and the metoprolol. So it's also going to mask the hypoglycemia in diabetics because you're not going to get the tachycardia or the tremors as warning signs. So another thing is never stop it abruptly, right? Because that's when you get the rebound hypertension. Okay, I hope this helped. Thank you so much for listening to all of this. I really appreciate it. So yeah, let me know if you have any questions. Great, bye.